Thank you. Good morning or afternoon, where everyone's located. I am going to share my presentation and just double checking that you can see the slides. Okay.
Yes, I can see the slides.
All right.
And I'll moderate today. And anyone who has any questions, feel free to put it in the chat, or we'll have questions as well at the end. Thank you.
Sounds good. Well, I just wanted to start off by saying that I have no conflicts of interest for this presentation, and all opinions that I share are my own. Let's see. Okay, here we go. Jagd she Natalie Jo Yenishia, Madish Gishni and Shlon, Haskanzo Bashichin, Kiltachini Dashiche do Klizatana Dashanala, Akote Goaston Nishlin. So I am an enrolled member of the Navajo Nation. I am from the Coyote Pass Hemis clan, born for the yucca fruit strung out on a line clan. And my maternal grandfather's clan is the Red House clan, and my paternal grandfather's clan is the Many Goats clan. And I'm excited today to share about my journey from cancer biology into Indigenous cancer health, what I work in now. So a little context, as everyone may be familiar from the University of New Mexico, but I did grow up on the Navajo Nation. So here's where our 5 agencies sit in the Southwest, specifically in Red Valley, New Mexico, or Red Valley, Arizona. And it's pictured here on the bottom right. This photograph was taken from the top of what's called Bear Mountain, and the home where I grew up was right below the mountain. And then in the center are my maternal grandparents, who live down the road still in Red Valley, who I spent a lot of time with growing up. And anytime we needed to go to a bigger store or town, right, we passed Shiprock Rock. The reason why I started to work or even just get an interest in cancer research and the entire biomedical field was because of a historical event that happened in the mid 1940s through the mid 1980s during the Cold War. So in the Southwest, there was about nearly 30 million tons of uranium ore that was extracted from the area. And as you can see, many Indigenous people in the region worked in these mines. And photographed here, you notice that they have hard hats, but there's not really a lot of other personal protective equipment. This was even after it was known there would be adverse health outcomes from being exposed consistently to that uranium dust. And the data specifically for the occupational exposure would kind of come to light later down the line to see those kidney diseases as well as cancer outcomes. But I learned about this instance growing up from more qualitative data and not quantitative data. So my mom would tell me about how her uncles worked in these mines and that they would come back home to where all of her siblings are, and they would still be covered in the dust, and hang out, pick up, hug, as well as their clothes would be co-washed. And so this I heard through story about secondary exposures to that uranium dust. And really, it was these conversations that led me to want to do something about cancer for our communities. A way that we can see this specific data really comes about from having information about individuals who develop these diseases later down the line. And the kind of big realm of research that this encompasses is cancer surveillance. So I wanted to first highlight what is cancer surveillance. So within the general population, there will be individuals that will develop cancer. And these individuals may be different ages, they may live in different locations, and they have different life experiences. So how do we start to realize what's the difference between individuals that develop cancer versus the rest of the population that currently doesn't have this disease? So one way to start to get information about cancer disease development in a population is to collect, first the date of diagnoses, the specific type of cancer, as well as location, and further information just about these specific individuals in the population. So once this data is collected, we can start to get an idea of the proportion of the population that has this disease burden in relation to the total population. So for instance, for breast cancer, 1 in every 8 women will develop breast cancer. And we know this from population level cancer surveillance data. Now, what are some other questions that we can answer using cancer surveillance? So this would include looking at the previous year in 2025, how many people have developed cancer. To answer this, we calculate incidence rates. So for 2025, this was around 2 million people in the US. Another question that we can ask and get the answer for is in 2025, how many total people have cancer? So these are prevalence cases because it's not only confined to that 1 year, but it's individuals who've had existing cases plus the newly diagnosed. This is around 18 million individuals in the US. We can also ask, as of 2025, how many people who were diagnosed with cancer 5 years before are still alive? And that's a calculation of survival rates. These, again, are specific to different subtypes. So for breast cancer, if it is diagnosed while it's still within the mammary fat pad tissue, on average, individuals live for, on average, 90% of individuals live for 5 years after that diagnosis. So these are highlighting what kind of questions can you answer with cancer surveillance, but why is it important in the first place? So once we have cancer surveillance data, we start to gain information about the overall health of a specific population. And understanding these differences in cancer burdens helps us start to target priority specific areas. So we can plan interventions to start to reduce some of these cancer burdens. This goes beyond public health into more policy. So this will really prioritize where resources are allocated. And once we collect this over time, we'll start to see what's the trend of cancer burden within the populations. It'll also help us see, okay, if we implemented different intervention programs previously, was there an impact long-term on the cancer burden for a given population? One limitation, though, for only using cancer surveillance is we can ask really broad questions at the large level for a population, but it doesn't give us information about specific, cellular mechanisms as well as other aspects of the entire fields of cancer research. So I want to highlight some of the fields that I've worked in during my training, because it takes a lot of different researchers and scientists across a lot of fields to really get to the goal, of eliminating cancer. But today I will focus more on the latter half of my research journey, specifically the pivot from bench science into public health. So this splits into 2 different areas in my training as well as where I'm currently working now. I will discuss my dissertation project that I did at Johns Hopkins School of Medicine, as well as highlight work from my postdoctoral fellowship and what I'm continuing to do now as an assistant professor. So in the first half for cancer biology, what are some of the questions that we can answer using techniques of biomedical research? Specifically for my dissertation work, I was focused on testing new cancer therapies and seeing how effective they actually were at doing what we wanted, at reducing cancer growth as well as treating cancer in a living model. So to answer these, one of the first questions is, does this new therapeutic inhibit cancer cell growth? And if it does, we're trying to figure out, how is it working, What's the mechanism behind this? Then going from the cells alone, we'll go into the living model. And during my PhD, I worked with mouse models. So you want to see, is it doing the same thing we saw in the cell culture dish as well as in mice? And if it is, well, how is it working now in these mouse models? Is it the same that we had anticipated before? Another question we can ask in mouse models is, does this therapeutic prevent the cancer from leaving the primary site? So for breast cancer, it starts within that mammary fat pad, but cancer cells, as they grow, start to get specific cellular behaviors where they leave that first site, enter into the bloodstream, and then will seed into another organ and start to grow. And since it's a secondary site, that's what we refer to as metastases. So now we can start to ask, is that reduced? And if it is, well, what could be a mechanism that's reducing this other path? The work that I focused on is labeled preclinical cancer research. And it's called preclinical because it's everything and all the evidence that you gather before this new therapeutic actually gets into the clinic with people. One way that this research is conducted, specifically for the work I did in breast cancer research, was it starts with a person who starts to grow that primary tumor and then gets a diagnosis. I was interested in the specific subtype of triple negative breast cancer, and it's called triple negative because it doesn't have the three common receptors of estrogen receptor, progesterone receptor, human epidermal growth factor receptor 2 on the surface of these cells, which actually will start a signaling cascade that helps the cancer cells grow. So these are all absent within triple negative breast cancer, and it's characterized because we don't have a lot of targeted therapies for this specific aggressive growing cancer. So for preclinical and the work that I was doing, that starts with an individual who has this primary tumor, and then the primary tumor by a physician is removed and we grow them outside of the person. So we can grow them in two different locations. The first in a tissue culture dish and the second being in a mouse model. So once it's growing in that tissue culture dish, we can set up an experiment where we're looking at what's the difference in the cellular growth when we treat some with our drug and therapeutic of interest and some without. And again, you're plating them at the same time and seeing the difference in growth patterns. Then you can take these cells as well and either directly put them right into the mice. So then again, it's another route. So it can go directly from the tumor being in the person and continuing to grow in a mouse model, or you can grow them in a dish first and then implant them back into mice. Now, the mice that I worked with, a majority of them did not have an immune system or lacked certain components of their immune system, because when you take another species cells, so human cells, and put them into mice, usually that triggers an immune response in the mouse and they'll start to fight off that kind of foreign body that you're inserting into the mammary fat pad. But once you reduce or remove their immune system, then these cells will continue to grow in a similar tissue in mice. So then you implant the mice and then you treat a subset with your therapeutic of interest and the subset without, and you see again the difference between the growth at that primary site as well as seeing if there's an impact on reducing metastases. And as I mentioned, the whole goal of this is to start to figure out, one, is this drug effective? Two, how is it working? And three, if there's enough evidence, well, then this can inform how it can be used in the general population. The therapeutic that I worked with is mebendazole, and it's already an FDA-approved drug, but for the use as an anti-parasitic. And I was using it in the context of triple negative breast cancer because the laboratory I was in had previous research that showed it was effective in preclinical models for brain cancer as well as for thyroid cancer. And then one highlight that I want to show from the work that I conducted during my dissertation is from the mouse models. So I'm going to show some of the images of mouse work, specifically some mouse organs. So if you really don't want to see that, I would suggest kind of stepping away for about 30 seconds. It's only going to be one slide, and then you can return after I show these images. All right. So upon treatment in mouse models, Here we're looking at distant metastases. So I implanted within the mammary fat pad, and then at the end of the experiment, removed the lungs of the mice in the control group. So those are the mice in the top row. And then under that are the mice who were given the mebendazole treatment. The cells that I put in were tagged with a fluorescence. So that's why we're seeing these kind of purple dots pop up. And just visually comparing between the top row and the bottom row, there's a reduced amount of fluorescence in lungs. So therefore, mebendazole is reducing metastases, the breast cancer metastases to this lung site. In addition, another site, the mouse model that I used metastasizes to is to the liver. So again, at the top here with labeled CON is the control group, and at the bottom are mebendazole treated mice. And there are more nodules of fluorescence from the breast cancer metastases in the control versus the mice that were treated with mebendazole. And the work that I did in cancer biology really helped me get a foundational understanding of the way breast cancer cells behave in these two controlled systems. So in tissue culture, right within the cells, as well as in the mouse models. But the part that I was still missing at the end of my dissertation was kind of what started my entire journey in cancer research, which was there wasn't a direct connection to Indigenous communities. And in the field at large, right, for cancer bio, when you're really focusing very detailed into mechanism, you're not really looking at identifying individuals who are at higher risk than other people, and you're not looking at what are the differences between populations. So it was really these three missing points that led me to move and pivot into the field of Indigenous cancer health for my postdoctoral fellowship, as well as for where I work or what I work in now. And my start into Indigenous cancer health began with cancer surveillance data, because this data is very important to get as accurate and high quality of the data specific to Indigenous communities at both the collection as well as when you're doing the analyses. And here's where I really started learning how to be a good steward of Indigenous data that I'm using in all of my analyses. I highlighted and kind of pointed out specifically Indigenous data, because this does not only encompass what I talked about at the beginning for cancer surveillance, which is more coming from a Western science point of view. Indigenous data also includes information about whole communities, so full tribal nations, as well as the resources and environments that Indigenous people live, or where Indigenous people live as well. So just trying to get a full picture. Now, working in this area of public health, I want to highlight some of the questions that we can ask in this specific field that we weren't able to ask using cancer biology techniques. So within what is currently known as the US, how do we calculate Indigenous specific cancer surveillance rates? And really trying to figure out what are the limitations to the current methodologies that we are using to get these larger population incidence, prevalence, and those survival rates. Now, how also can we work to get tribal nation specific cancer surveillance data? And to do this, what are the partnerships that are needed to build, or what partnerships need to be built in order to access as well as share the data? I will highlight two ongoing current projects at different levels of the cancer surveillance landscape, starting with the full national level. This is where we get information about the entire American Indian and Alaskan Native populations regarding cancer burden. The first project really focuses on determining what's the impact of implementing a new racial and ethnic categorization. I'll do some background review of where does the data set come from that I'm using, as well as talking about what was the previous methodology and what's actually being updated. So the data I'm using is coming from the National Cancer Institute's SEER program, and SEER stands for the Surveillance, Epidemiology, and End Results Program. SEER, the idea of this data set and program came about during the National Cancer Act in 1971, but it wasn't fully created till 1973. The purpose is to collect, store, and analyze, as well as disseminate all of the cancer data for researchers to start to answer questions about cancer prevention, diagnoses, as well as treatment. And we celebrated the 50th anniversary of SEER in 2023, so now it is 53 years old. But at its onset, the SEER program covered a little less than 10% of the entire US population. But as of 2023, it's up to nearly 50% of coverage in their data set. Now, this again is encompassing all races and ethnicities specific to SEER, but my work is specific to American Indian and Alaska Natives. So how do we start to calculate that surveillance data? Well, first, there are three specific methods. So we do classification of individuals, then we restrict that specific population, and then we also bring people in who were racially misclassified. So starting first with the racial classification, this is actually coming from an older method from 1977. And this was created by the Office of Management and Budget. So they made the first racial and ethnic categories that people select at the population level, so via the census, as well as what we use to identify those individuals who are in cancer cases. So once we have everyone who has been identified as American Indian or Alaska Native, then we restrict down to a population who are non-Hispanic, as well as those who live in specific counties. So the reason why we look only at the non-Hispanic population is because in the census in 2000 to 2010, there was a large increase of Hispanic American Indian and Alaska Natives. And this large growth was faster than the average natural population growth. And so there are two hypotheses as to why we saw such an increase in Hispanic American Indian and Alaska Native populations. One is that there was a lot of educational efforts to really use the racial category of American Indian and Alaska Native to what it was originally classified as, which includes individuals who are indigenous to Central America. So people who didn't identify possibly before as American Indian and Alaska Native and who select Hispanic ethnicity may have been using this category as it was originally intended. And a second reason is coming from a problem with the census imputation. So when people were filling out and self-identifying, if you selected Hispanic, but then did not select a racial category, some people in that unknown race were allocated to the American Indian and Alaska Native populations. So these two reasons are what we in the cancer surveillance field hypothesize is why we saw that increase. Now, the other restriction is specific to geography. So it's where Indian Health Services provide their federally mandated healthcare in purchase referred care delivery areas. So these are counties throughout the US that are near or on tribal reservations and land trusts. And the thinking behind this is to ensure individuals put into our data are indeed American Indian and Alaska Native. But there are still people who are misclassified within the data. Previous data sets and analyses have shown more often than not individuals are classified as non-Hispanic white who are American Indian and Alaska Native. And the way we bring those individuals back into our data sets is through a linkage with Indian Health Service. And these are with health records. And the only way you can get services at an IHS clinic is if you are an enrolled member of one of the federally recognized tribal nations. So that's, again, bringing those who have been misclassified. So this is historically how we get population level data across the US regarding Indigenous communities. However, there was an update specific to the classification categories in 1997, and it's taken almost now 3 decades for it to be rolled out and implemented. And this will start to happen as of next year. So my work right now is to really figure out what's going to be the impact of this update. So to give you an idea in general of how we previously used the 1977 classification to the update, I'm going to go over an example with 3 fictitious individuals. So here we have one person who self-selected to be American Indian Alaska Native race alone. We have a biracial individual who selected American Indian Alaska Native and non-Hispanic white, and a multiracial individual who selected non-Hispanic Black, non-Hispanic white, and American Indian and Alaska Native. Now, if you look at national data sets right now, what you're looking at is more often than not bridged race. And these bridged race, this bridge race population is coming from a survey that was conducted between 1997 through 2000. It's the National Health Information Survey that was rolled out by the Center for Disease Controls, or the Centers for Disease Control. And what it asked was individuals who selected more than one race. If you were to choose one race to represent yourself, what race would that be? So then we computed bridging race factors for biracial and multiracial individuals, so then we can bridge them back to those 1977 categories. So there's more methods and statistics underneath this, but for simplicity, more often than not, the 3 individuals that I created here would be placed within the American Indian Alaska Native category. And then within NCI, the National Cancer Institute, there is another way we categorize people, which is through an in combination rates. And here in the surveillance research program, we're trying to address, the fact that we're not really allocating everyone to every racial category that they identify with. So here we're counting individuals in each category they selected. So American Indian alone, or American Indian Alaska Native alone and in combination, non-Hispanic white alone and in combination, and then non-Hispanic Black alone and in combination. When you look at data coming from the surveillance research program, sometimes you'll see in combination, but for national data, you're looking at bridged race. Now, what is that update from 1997? What will that look like? We're moving toward changing toward a lone race and a multiracial category. So now with the 3 individuals at the top, only the first person who selected only one race will now be counted in the American Indian and Alaska Native population. The other 2 individuals would be in the larger multiracial group, which is not specific to every race. It would be for anyone of any race who selected more than one race. So now that calls into question of how do we start to interpret that multiracial category, and what will that do to our overall cancer surveillance data for American Indians and Alaska Natives? That's the main focus of my first project. And again, that's at a broad level. Then I wanted to highlight a second project at the tribal nation level, working with Navajo Nation. I am presenting this work as a part of a larger collaboration, and the Navajo Cancer Work Group was created in the 1990s, and I joined like 3 years ago. So again, this has been decades of work before I joined. The collaboration spans across Navajo Nation government, federal agencies, as well as nonprofit orgs, academic and research institutions, the state governments, and cancer registries. So it really takes a very large project and different data sharing agreements to get this work done. So I want to share 2 of the main products that come out of this work group. The first being a cancer surveillance report entitled Cancer Among the Navajo. The third one was just released more recently, showing data from 2014 through 2018. You can download these surveillance information from the Navajo Epidemiology Center's website. Another thing on the website that's coming out of these data reports is the data dashboard. It is still new-ish. It's about almost 2 years. I think it's been like 20 months. And since it went live, there's been about 1,600 views to the cancer data dashboard. At the bottom, you can see all of the different organizations that have been in the partnership. And here, I wanted to walk through what does it look like as you kind of click through the tabs. So first, it'll give you general cancer case counts, and you can look at the most recent cancer surveillance data report. So that's, as I mentioned, the 2014 to 2018, as well as look at the data by gender. So here is combined of both males and females. And so you can get quick glance of what are the highest cancer burdens and what are the subtypes, so female breast, colorectal, kidney, prostate, uterine, and stomach. And then you can look at the incidence rates for both report years. So from the 2014 to 2018 is the darker blue, and then 2005 to 2013 is the lighter blue. Then we're doing a direct comparison, again, to highlight the disparities between Navajo and then non-Hispanic white individuals within the Arizona and New Mexico states. Then you can click through. This is showing all cancer sites, but you can go through the top 10 cancer sites, and again, by gender, so combined or male and female alone. There's also cancer staging information, so at what stage was it at when it was first diagnosed. And for the 2 specific reports, this is only specific to 3 cancer sites, female breast, cervical, and colorectal cancer. Then going more into the survival, like the mortality specific data here, looking at the top 10 sites, as well as, again, you can look through the 2 most recent reports, and then again by gender. Then the rates comparing Navajo people to the non-Hispanic white population within Arizona and New Mexico for the 2 reports, and again by gender. I really wanted to highlight with a large partnership, what are 2 big products that can come out specific to cancer surveillance. So we have the dashboard as well as continuing to update those reports. And these 2 efforts have informed the developing of a cancer control plan that's being led by folks. A majority of the folks are from Northern Arizona University. So I really wanted to highlight their work and their specific efforts. But one limitation to the data that I was showing is, it's coming out of the Navajo Epidemiology Center, but it's not using tribal enrollment data. So the way that we're getting that data set is specific from counties that overlap Navajo Nation. So included in these data sets are anyone who lives in those counties and received that cancer diagnosis, as well as the underlying populations who self-identified or have been identified as American Indian and Alaskan Native. So this data represents Navajos as well as all of our Indigenous relatives in tribal nations spanning New Mexico, Arizona, and into Utah. But right now, this is the best estimate that we have with the data set that we have access to. So I'm hoping that these 2 projects really highlighted, what kind of questions can we answer, and why is it important to have the cancer surveillance data for our Indigenous communities at the national level, as well as for an individual tribal nation. And really, this work has led into what I'm continuing to do as an assistant professor to really figure out what's happening with our Indigenous communities and how can we respond to the high burdens that we see. So taking a cancer bio background and the methods that I used in cancer surveillance science to really center our Indigenous communities. And the Department of Indigenous Cancer Health, we focus not only at the local level, so we're located in Buffalo, New York, so the greater Western New York region, but also nationally and internationally. And I really aim to empower our Indigenous communities with their own cancer surveillance data from that Western side of individuals, but also gathering qualitative data because there's Indigenous knowledge to be incorporated into this work so we can co-create cancer intervention programs that really reflect communities' priorities. And I really appreciate sharing my journey with you today. I want to give some acknowledgments of, all of the support that I've received throughout my cancer research journey. So for my support system, here pictured are my family, my wife, and our fur baby, as well as for my friends. And shout out to my new team at Roswell Park here in the Department of Indigenous Cancer Health, as well as all of the mentors and sponsors I've had across my full training program. All the collaborators that I work with in academic and research institutions, past and present, as well as for the funding and support information. It really varied by project and institution. So I'd be happy to take any questions. Here's my contact information. I'll be sure to put it in the chat as well. Feel free to reach out if a question comes later on or if you have more of a specific question later. And here are my references. Yeah, thank you.
Thank you so much, Dr. Joe. Oh my gosh, this was a lot. And you broke it down so well for a lot of us who are not specifically in the science field, the hard sciences. So I appreciate that. It kind of reminded me about a lot of the training I got as an undergraduate. I also kind of took a short path in cancer biology, but I just think it's so remarkable that, there's so much work and effort being done to put this all together. And I have a few questions, but let me see if there's anyone who would like to ask a question before I do. Okay, so we have a question from Samuel, Dr. Swift, who asks, can you talk more about your really important and interesting first project? Are you seeing big differences in preliminary analyses? If the classifications do change in their rate significantly, can you talk more about the implications for interventions in public health practice?
Yeah, definitely. Thank you for the question, Dr. Swift. So some of the results that are, kind of coming out, and it's not really a question of if we go there, it's when. So this will be implemented as early as next year. So it's already starting with the mortality data set, and now it'll move into the incidence specific data set. So we can't really stop. So how is it actually going to impact? And in cancer surveillance, there's really this mismatch between how we identify the individuals and cancer cases versus the general population, right? Because the general population data for American Indian and Alaska Natives is coming from the large census data. And we've seen the rates decrease, right? And so now it's a question of, are they decreasing due to the classification of a mismatch between population and those cancer cases? And how can we, differentiate? Because even just one specific, incidence rate for all natives for the US doesn't really show the big picture of what's happening. And so one effort we're trying to do is really break down, because there's difference by geography. So for instance, lung cancer rates are low in the Southwest, but they're high in the Northeast for Indigenous communities. So some of the things through the American Indian Alaska Native, like Cancer Data Task Force from NACER, which stands for the North American Association for Central Cancer Registries, what we're trying to work on is, one, get a really good idea and then hypotheses behind why are we seeing these differences and what's really impacting it. Three, can we make a white paper, so a protocol for others on best practices? So when you're seeing these differences, what's actually happening? And in collaboration with NCI through SEER, also adding in language on why are we seeing these differences between previous rates for American Indian Alaska Native people, and why are we seeing this difference? So again, still kind of trying to parse out, we are seeing lower rates, but what's underneath that? And one caveat for the data set that I'm using, right, is, as I showed, it's only 50% of the population, and it's for areas that are within the SEER Cancer Registry program. So again, we're still not seeing the full impact across all of the US.
That's a really good question, Sam. All right. Any other questions from the audience? Well, I had a question. I was curious about, I'm just so amazed, where you are today. And I know it takes a lot to travel away from, the Navajo Nation and represent and also go into academia. It's very challenging, but I was just curious, like, what is it that I know that you mentioned that your family had faced the impacts of uranium mining, but
Mhm.
you also journeyed onto getting a bachelor of science in Fort Lewis College.
Yeah.
How did you jump from Fort Lewis to going into this path and getting to your PhD program? What was it that kind of motivated you, or what helped you along the way?
Yeah, great question. So I feel like depending on the talk framing, right, it seems like a very linear trajectory, but my interest has always been to try to, help eliminate cancer. At first, I thought, okay, what's the way I've seen people, in TV or what I've read about help within cancer? And that was through being a medical doctor. So I read Dr. Lori Arviso Alvarez's biography, the first Navajo woman surgeon, and thought, okay, I really want to be a doctor. So starting from middle school all the way into starting at Fort Lewis in undergrad, the goal was to go to medical school. And a part of that application required some previous research. And that's when I got into inorganic chemistry research, making anti-cancer prodrugs at Fort Lewis College. And I really liked being an active part of discovery, right? Of being at the forefront of research where physicians, you're really using the tools that you have today. And in cancer research, you start to build those tools for what we can use tomorrow or in the future. And I liked it so much that I pivoted. So I thought, okay, well, maybe not medicine and then moving into research, but as I showed, there are so many fields and so many questions that need to be answered across the board. So I, in undergrad, was in chemistry, also did some biochemistry work, did a summer internship in a cancer immunology lab, and decided, okay, I've done 3 years where we're making the therapeutic. I want to know what happens after. So then that's why I went to cancer biology for the PhD, was learning, okay, how do you input it? And I applied to 10 different PhD programs that I found because I attended the SOCNIS conference, so the Society for the Advancement of Chicanos, Hispanics, and Native Americans in STEM. And they had this huge expo hall where you can walk through and there's all of these, graduate programs that are trying to recruit students. So I grabbed all the brochures and flyers, chose 10 and said, this is what I'm going to apply to. I applied. I got 2 swift rejections. And then the other 8, I received offers to interview. And so then I went out, interviewed, and then chose there. But I had the backup plan of, okay, if I apply to all 10 and there's nothing, I had a stack of post-bac programs that I was planning to apply to because I still wanted to stay in research. And that was really, what kind of drove me to do that pivot. But it was scary moving 2,000 miles away from home, of going from Fort Lewis, having a large population of Native students, to going to Hopkins, where I felt, it was in my program and only. It was a big adjustment, but I feel like I learned a lot from that experience. And I think that sense of adventure comes from being younger. I was like, oh, I wasn't thinking of all the details then.
Great, thank you. It's such an
Yeah.
amazing journey. We do have another question. Cassie asked, the racial categories history is important. I'm always baffled how we get things so wrong, especially with the Latinx Hispanic populations and being lumped into white classifications depending on the way the data is collected and people's confusion. Thank you for showing us the backstory and what is being done to improve data collection. What qualitative information is needed?
Yes, great question. I think it's really hard within the cancer surveillance, field because it's really coming from a white colonist perspective, right, of how they have classified people. And then we have to figure out how to do the work to fit who we are into these categories and then interpret this. So I feel like it really doesn't do justice to any of our, Black and Brown communities of who we are as a people and really getting the diversity and heterogeneity in a population. Um, so I feel like there is that qualitative work that needs to be done of, okay, how do our communities, classify who's a community member, or how do we self-identify? And then how can we inform all of the bigger agencies like the census, cancer registries, and start to change how the system categorizes our populations. And I think it's a long-term project, but the qualitative information, gets right at the question first and foremost. And I think it'll be a while before cancer surveillance data really catches up to then.
Thank you. We have someone whose hand is raised. Feel free to unmute and ask your question.
Dr. Joe, so nice to see you. Thank you so much for coming and, speaking a little more about your journey. It's always fun to get to know you a little bit more in every interaction we have. For folks that don't know, Dr. Joe and I have shared the same NCI Cancer Prevention Fellowship Program, by the way, which is accepting applications right now. Just a little plug. Natalie, you're far away, so some of us are here. I'm wondering if you would have some advice for all of us here as you're looking at some of these larger data sets and larger, patterns in the population. What are some things that we should be doing on the ground over here? What are some interventions? What are some ideas that might be um, helpful to bring to the communities, and perhaps we can also collaborate with you in bringing all of that to the communities here. So I was just wondering if you had any ideas around that, and or any future directions you're taking as you're starting your faculty position, and so would love to hear more of that.
Yeah, thank you for the question. I would, really point you in the direction of more senior people than myself, who, as I mentioned, are part of that Navajo cancer work group that's been ongoing for decades. I feel like they've gone through the trial and error of building that specific partnership. So, really trying to figure out, okay, how can we expand this to other Indigenous communities, but as well as implement the same practices for other communities, right? Of how do we empower communities with their data? How do communities want to actually put priority on different cancer burden? So I feel like just following that model of using the data that we have access to now, really understanding what are the limitations, like who's really included in the data that we're showing, and is that reflective of how communities see themselves, and then trying to figure out, okay, if there's a disconnect, how can we speak to that and fill that more with qualitative data, and then really build interventions from there. So I feel like just building that, I envision, everywhere having this cancer prevention ecosystem, right? That's both the research institutes and then federal agencies plus communities all, co-sharing, like having that power sharing structure underneath it. But yeah, a very long-term work. I hope that answered your question.
That's great. Are there any other questions before we close today? Natalie has also shared her email, so feel free to reach out to her if you have any other questions. All right. Do you want to have any closing words, Natalie, before we end today?
Well, just, thank you everyone for spending your afternoon here. I really appreciate it. And yeah, feel free to reach out and ask any questions that you have. I really, encourage everyone to pursue where their specific passion and drive is, because we need everyone in every field, even outside of science, right? In the arts and in every field. So again, there's not really just one way to get there, and you only learn what you like by trying, a specific field. Because like I said, I thought I'm going to be a doctor, and now I still technically in the doctor, but not medical field. I'm more in the mouse doctor and cell field. But yeah, thank you everyone. Yeah.
Thank you so much, everyone. Have a wonderful day.